David's like, hello.
Okay, so I think we are now recording, so we minimize that, bring our screen back up. Okay.
Yes.
Sure. Rachel and Derek for the meeting.
Okay, so Shane, what do you think?
Stasis mucinosis.
Why stasis mucinosis instead of pretibial myxedema?
Upper third row.
Because it's upper third instead of all the way through. And that's exactly what it is stasis mucinosis. So some of the clues, it has nodular angioplasia. It has plenty of hemosiderin deposition. When you look at the lower dermis, there's plenty of hemosiderin, but the collagen is not attenuated. In true pretibial myxedema, the collagen is little wisps all the way to the base, all the way through the dermis, replaced by mucin. And the best study was the one out of Cleveland Clinic, Wilma Bergfeld's, where they looked at upper third versus through, and through was associated with thyroid abnormalities, and upper third was not. It was associated with stasis. So pretty much answered the question. So upper third only, stasis mucinosis. Look for other changes of stasis. Through, mucin deposition, more typical for pretibial mix. And you should have alteration of the collagen all the way through. Okay, David, what do you see?
Yeah, clean subepidermal split.
Okay.
Maybe some festooning. So I'm thinking probably PCT. Yeah, some more caterpillar bodies, maybe.
Caterpillar, or as our kids said it when they were little. They say not caterpillar, but cat. I can't even get it wrong, really.
Caterpillar.
Whatever.
Yeah, that's right.
Doggy prison.
Yeah. It was like Kappa something. But anyway, caterpillar bodies. You got, which is trapped basement membrane zone where it's blistered before, sandwiched in the epidermis. And one of the other characteristic things for PCT, it will always have solar elastosis. If there's no solar elastosis, more likely probably a pseudoporphyria, not a true PCT. I mean, I don't think I've ever seen true PCT without solar elastosis, whereas EPP will never have solar elastosis because it hurts too much when you're in the sun, right? So we got that here. Okay. What do you think we're looking at, and what do you think the stain is?
So the stain might be
so you got all of these masses here, and it's sort of cracked and fissured in areas.
yeah, so the stain it's kind of brick red. So
Yeah.
the Congo red stain.
Yeah. So Congo red, and for those on monitor, it's showing up kind of yellow, but that really should be brick red, which is typical for Congo red. So fissured masses and Congo red, the apple green birefringence is typical, and you just use polarized microscopy to see that.
So it looks like we have a lot of mucin in the center, almost like a nodule.
Yep. And what if it's focal and cutaneous?
Probably focal mucinosis.
Yeah, focal mucinosis or focal cutaneous mucinosis, which is just a pure description of what it is, right? Looks pretty much the same as a myxoma like you might have in carnes. So focal mucinosis and a focal localized myxoma are basically the same thing. So if you have multiple of them with blue nevi and endocrinopathy, you've got carnes. If you have just one of these and you think it's a neurofibroma when you take it off, but all you see is mucin, then that's just incidental focal cutaneous mucinosis.
So it looks like the
And the
They
whole thing, it's
really-
kind of sort of
yeah.
sliding off to the side there, but that's your biopsy.
collagen's really thin.
Really thin, and what do you think might be replacing it?
Probably mucin.
Probably mucin, and so mucin you will see if the lab only runs skins. If the lab also runs GI specimens, then they tone down the hematoxylin, and then mucin is invisible. So you see fenestration between collagen bundles, but no blue snot. So
I would say it's probably pre-tibial mix since the collagen's so thin.
yeah, collagen so thin all the way down. That's typical for pretibial mix as opposed to what we just saw for stasis. Stenosis. Let's see. Lots of repeats in here. Let's do that.
What's that about a mucocele?
Yeah, like a mucocele if it were oral mucosa. Does it look like oral mucosa with that big thick?
No, it's got a granular layer. It kind of looks apical, so maybe it's digital mixoid.
Yeah,
Says-
and they're really not that different. In a mucocele in the mouth, it squirts out from a minor salivary gland, and in a digital mucocyst, where's it coming from?
Synovial capsule joint
Yeah,
space.
DJD, and it's just leaking out and getting to the skin. And then over time, you get metaplastic synovial change and fibrosis around the mucin in both locations. So they can look very similar, like a ganglion cyst anywhere. When you're dealing with a digital mucocyst clinically, always see if it's reducible. Most of them, you can press as hard as you want and they're not going anywhere. Others, you press and it all squeezes back into the joint and you let go and it slowly fills back up. Well, that one may shock you is connected to the joint space still, right? And so in that one, you probably want to tie off the little connection to the joint space. I've never seen an infected joint space from treatment of a digital mucocyst. But high rate of recurrence you get. And I think they don't infect probably because it's an exit flow. So things, it's all being washed out of the tract. One of the things that you can do is you can inject a little tall blue or methylene blue, and it shows you where the little thing is that you have to tie off. So that's been done.
You inject that into the intact.
You inject it into the
Before
intact.
opening it.
Usually what you do is you reduce it,
Mm-hmm.
then inject a little bit so that it's not diluted by all that mucin.
Let it sit for a bit, and then.
Yeah, let it sit for a little bit, and then it fills back up, and it leaves a little stain in what you have to tie off in the connection.
This is there is abdominal is normal, and the nodule with the reticular pigment incontinent. So this is the lichenoid amyloid.
Yeah, so like an amyloid or macular amyloid would look similar. Macular amyloid is caused by chronic rubbing or scratching from Notalgia paresthetica. Lichen amyloid is a manifestation of chronic lichen simplex chronicus. In both cases, you're constantly rubbing, scratching, and so you get keratinocytes that mummify into a keratin-derived amyloid as opposed to an immunoglobulin-derived amyloid. And one of the hints that differentiates the two is you always, as you said, have a reticular network of pigment around the epidermal-derived amyloid, around the keratinocyte-derived, whereas you never have that around the amyloid that's primary from immunoglobulin.
A large piece of tissue.
Large piece of tissue.
Fat. Not sure if I see any epidermis.
I agree, I don't see any. So what do you have there?
Looks like you have some dark blue or purple staining material in a vessel.
Which likely represents?
Calciphylaxis.
So if it's a
Or if
big
it's thrombus in
vessel, is that diagnostic for calciphylaxis?
I think you need to have it in the small.
Okay, so the point is, these are diagnostic for calciphylaxis, right? Every last little capillary calcified. Whereas the big ones, that's Munkeberg's medial calcific stenosis, which is atherosclerotic disease. So big vessel is commonly there. That just means you have atherosclerosis. What defines calciphylaxis is all the little capillaries that are calcified. Basically, you crackle when you walk because everything has gotten calcified. So, let's see.
Looks like there's a subepidermal split.
Subepidermal split.
And some caterpillar bodies mixed in there.
Yeah. Makes you think of
PCT.
PCT. Okay, what else gives you subepidermal splits that are paucicellular, pauci-inflammatory?
EBA.
So epidermolysis bullosa acquisita. What else?
I know bullous lupus can, but I don't know if that's posse immune.
So bullous lupus, usually a little more inflammatory when it looks like dermatitis herpetiformis, but some bullous lupus occurs because of liquefactive basilar change. Just your interface is so bad that you get a big Max Joseph-like space, as in lichen planus. So bullous LP and bullous lupus can form just because of all the death of the basal layer. And then bullous lupus has the more common form that's neutrophilic, like dermatitis herpetiformis. The one that's liquefactive is more likely to be pauci-inflammatory. What else? Things like BP, immunobolus can be. Another really big one is urticaria pigmentosa. Bullous mastocytosis. You may not see that many mast cells. You know, it may look like a relatively pauci-inflammatory bullous, so that's another one in the list. Coma blister, where you may have sweat gland necrosis. All things in the differential there. Yeah, and in this case, you see, you know, your mucin is kind of blue and snotty in there. So, and the collagen's attenuated. And is it just at the top, or is it all the way through?
All the way through. So
Okay, so snot hard, right? What's the diagnosis?
Pretibial myxedema.
Pretibial myxedema. Right. It's not that often that in a professional setting you get to make snot jokes. So enjoy.
Lots of mucin.
Lots of mucin in this chapter.
It's focal and like a plaque-like focal mucinosis.
Yeah, so it's, you know, a little more plaque-like. What you want to know, is it just focal mucinosis? What other things can give you broad zones of mucinosis?
You have like a connective tissue disease.
Yeah, and when connective tissue disease does it, one of the old names was plaque-like mucinosis or reticular erythematous mucinosis. It's basically tumid lupus. So, it's a form of lupus that's mainly cutaneous mucinosis, chest and back, usually Latin females, chest and back, and uniquely responsive to hydroxychloroquine.
Bunch. It's like acral skin. There are some deeply purple, like basophilic structures that could be calcium, maybe amyloid, perhaps. Let's see.
And what do you think they are? What are they depositing on?
Looks like around vessels, perhaps, or nerves.
It's probably altered elastic tissue. They look almost like the banana bodies of ochronosis.
Yeah, like PXE logos.
Yeah, but it's much chunkier than PXE would be. And where are you on the body?
Acral, like palm, like that.
Yeah. So thoughts. This is usually like right on the marginal zone where volar skin meets the side of your finger.
Okay, is this annular elastolysis?
It's not an annular elastolytic granuloma, but there are a whole family of disorders that are kind of related. Acrokeratoelastoidosis, you get degeneration of elastic fibers and not so much calcification. You get sort of a breakup of elastin and too much collagen. The elastotic marginal bands on the hands are the ones that are more calcified, thicker, too much elastic, but they're all, if you're a splitter, they're different because of subtle differences in the connective tissue. If you're a lumper, they're all people who've worked outside with their hands, and they are all degenerative changes.
Dr. Carlson, would heel stick calcinosis be just a lot thicker calcium? From that, since it was acral.
Yeah, it's usually more focal, and looks a little different. It's not so much on the elastic fibers themselves that are degenerated.
Okay.
There's a recent referral, I think, right, from like the outside, not herbivore.
Yeah, we had
Patient with
a
that.
prospect.
Okay.
I think you guys are heated too, right?
Yeah.
Yeah.
Yeah, and I mean, you see them periodically. They come in fits and spurts. So let's see. It looks like that piece of tissue is what we have. So let's look a little closer.
There's certainly some pigment here in the papillary dermis. The cells almost look like spindled.
Looks almost like dendritic melanocytes, right? But if you stain it, it's not melanin, and it's not within melanocyte dendrites. In fact, if you put an elastic stain, that's all depositing on elastic fibers. And with time, those elastic fibers are going to become more and more ochre colored and thick. Yeah, early ochronosis looks a little bit like chrysiasis or argyria in the way it deposits. Can look a little PXE-like, except that, you know, it's not really black. You can already pick out that ochre. Anyone an oil painter? Ochre is a very old pigment that's like a brown, yellow brown. So it's not ochre like the vegetable. It's ochre like the pigment.
Been watching Bob Ross, so he
Oh, there you go. Okay, so it's kind of a muddy, ugly yellow actually, but it's it's the same color that deposits on the elastic fibers. But early ochronosis is going to be, you can make out the granular deposition before that forms the big thick banana bodies. That's the key.
So it looks like there's hyperkeratosis. The epidermis is pretty acanthotic, and then in the papillary dermis we have, I'm not sure if they're lymphocytes, like perivascular.
Yeah, definitely lymphocytes. And in some areas, an interface change. And how about in the dermis here? What are all of those pink chunks? Yeah, so that's all amyloid. And there's a tiny little bit of pigment there, but not a whole lot of melanin. It's there, it's just, not much. So huge deposits of amyloid in there that if you stain it is keratin positive.
It's either lichen or macular amyloid.
Yeah, and in this case, it's a lichen amyloid, but it's related to what's either hypertrophic lupus or hypertrophic lichen planus. Of the two, which is more likely to itch, lupus or lichen planus?
Lichen planus can be very itchy.
Yeah, so LP is the more likely to be very itchy. Hypertrophic dermatomyositis can also be very itchy. So this is a hypertrophic lichenoid dermatitis, possibly LP, DM, LE, and it's been scratched or rubbed so much. People are more likely to rub LP than scratch it because it kind of hurts when they scratch it. But it's been rubbed or scratched enough that it's produced a lot of amyloid, epidermal-derived amyloid.
It's a really big shave, and it's pretty thin. Superficially, the vessels look pretty normal, maybe a touch ectatic, but deeper.
And there's a little bit of...
Yeah, it's red cell extravasation.
Yeah, a little bit of hemorrhage.
Is that amyloid in the...
And all of this stuff is amyloid, and the hemorrhage is a clue. Amyloid vessels are brittle, they crack, and so amyloid tends to be purpuric. So, unexplained acral bruising is sometimes amyloid. Post-proctoscopic palpebral purpura is amyloid, just because of the fragility of the vessels.
A lot of blood.
So a lot of blood.
Large tissue. Don't say a lot of fat.
And this is probably where you get the best look at the thing itself. You have little vessels crisscrossing this very myxoid stroma with stellate cells.
Kind of. I mean, if it was all over, I'd think about like a thyroidy thing, but it's so focal and deep.
Yeah. And, the whole thing is myxoid tissue, myxoid tissue with hemorrhage. This one happened to be blopping around in an atrium of a heart. So it's just a big atrial myxoma from a patient with Carnes. You can get little emboli of these that flick off and you see in vessels in skin. This is just a little bit out of our scope of practice to read the atrial myxoma, but it's not that different from a digital myxoid cyst, just a huge blob of it in the heart. Jess, other things we should know about atrial myxomas
A lot of times
histologically?
have more pigment in them, like the regular skin myxomas are usually don't have hemocysteine.
So usually a lot of hemosiderin?
Yeah, I think so.
Okay,
Blobbing around.
so from blobbing around and all the hemorrhage, often a lot of hemosiderin present. Okay, so that's skin. All right.
In the first impression, there is in the deep derms emulsion deposit in the collagen bundles. So this is the scleroedema.
Scleroedema,
Edema.
correct. So scleroedema of Buschke, as opposed to scleroderma. Scleroedema is mucin in the deep dermis pushing the collagen bundles apart, and tends to be on the upper back of diabetics. But you can also see paraprotein associated that can be a little more generalized, but often back as well. And then you have the post-streptococcal. I've only seen that a couple of times. It's really dramatic. It's your entire body. And I think I've told you about the one guy. He had a strep throat. He was like a 32-year-old guy. Strep throat, and within about a month, he looked like the Michelin tire man. Could not bend his fingers, could not get dressed, could not wipe himself. His wife basically took care of him for 6 months as he gradually deflated and the mucin went away, and he regained the use of his fingers and hands. And he is on streptococcal prophylaxis for life because he never wants to go through that again. And it's just really dramatic when you see the post-streptococcal ones. And the average pebbly red one on an upper back is diabetic associated, usually type 2 diabetes. So scleroedema of Buschke.
Alright. Looks like there's a lot of kind of a blue-gray material deep in the dermis.
And what might that blue-gray material be?
Mucin.
Mucin,
likely.
snot, right? So you got snot in the dermis. So what's your...
This be a scleromix.
So scleromix, you should see the sclero part, which is lots of ropey collagen and lots of fibroblast nuclei. So papular mucinosis, scleromyxedema, which are on the spectrum, you have way too many fibroblast nuclei. Here you don't really see a lot of fibroblast nuclei. So it's a focal mucinosis. This is from a little kid. You can see how red and how delicate the collagen is, right? So causes of focal mucinosis in a child, especially if it's acral. So like hands, feet, ears, unexplained acral mucinosis in a kid. Anyone? Lupus. That's one of the ways that neonatal lupus can present. Unexplained acral telangiectasia in a child, unexplained acral mucin in a child. In things like ataxia telangiectasia, the telangiectasia comes way later. Early infancy telangiectasia is more associated with lupus, so is acral unexplained focal mucinosis.
It's a pretty pale staining slide. There might be
Pretty
increased
pale.
space down deep in between.
Yeah,
collagen
so
bundles.
if there maybe is a little increased fenestration down below,
Sclerodema.
then sclerodema.
And then a little subepidermal split. I think that's the capillary body running through.
So probably
Probably
PCT. In pseudoporphyria, give me some drugs that cause pseudoporphyria.
Main one that comes to mind are NSAIDs.
So yeah, with the big one being naproxen. Yeah. Okay, so this one, I'll just tell you this is a dog breed.
Maybe
And you can tell by the, all these clustered hairs that are, small hairs, and they're all in anagen. And there's often a muscle layer in the skin so they can shake off fleas. But you see all of this mucin, and you see how it's causing the skin to be kind of lumpy, bumpy. That's Shar-Pays are bred for cutaneous mucinosis. That's what makes a Shar-Pei is they look like they have pretibial myxedema on their whole body.
How do you diagnose it if the Shar-Pei gets pretibial?
It's one of the great tragedies of the world is a Shar-Pei with pretibial myxedema. Yeah.
Where did you get that slide?
From the Shar-Pei Club of America. No, from a slide trading club.
That's what pathologists do, veterinary pathology too sometimes.
Yeah, I mean we actually I have lots of monkey and cetacean. I have monkey from Texas. We had Southwest Research Labs was affiliated, and then the cetacean was from SeaWorld. So they're often where their pathologist brings things over for a look. So someone had a veterinary path friend who gave them a Shar-Pei biopsy.
That's pretty cool.
Okay, and then this thing, which is kind of mixoid and lumpy bumpy, is a human Shar-Pei, basically. Which is elephantiasis noster varicose on the leg. With that chronic lymphedema, you get a lot of mucinosis. It starts to look a little Shar-Pei-like. Let's see what else we have here. Oh, we got all kinds of things in the wrong box.
Shane.
Gosh, feeling my box, Blake.
Okay. So how about this one?
Well, it's almost a square punch.
Almost a square punch. And tell me about the space in the dermis. Is there too much or too little space between the collagen bundle?
Too little deep, so.
So too little, not too much. So this is the anti-sclerodema, right? And loss of periadnexal fat, which is what you started to say. So probably, morphia or scleroderma instead of sclerodema. Just the opposite, where you have loss of space.
So hair bearings, sebaceous glands,
Tells you probably where.
face.
Yeah, probably head, neck, face.
So a lot of, probably just a ton of mucin up there.
So
Or
there's
just really pale
mucin.
stealing collagen.
And tell me about the collagen. Is it normal bundles or is it small ropey bundles?
Small, ropey.
Normal number of fibroblasts or too many fibroblasts?
Lots of fibroblasts.
Lots of fibroblasts, ropey collagen, mixoid. Yeah, that's what scleromix looks like. So scleromix or papular mucinosis is upper third of the dermis, too many nuclei, ropey collagen, mucin. Similar change that starts down in the septum is what you see in nephrogenic systemic fibrosis. So NSF is down in the septum is where it starts and grows upward. Scleromix starts up in the upper third of the dermis and grows downward, but they have very similar changes with too many fibroblasts, mucin.
Do you make a comment about working them up further, sir? Designing that?
Well, yes. So we always make a comment about testing for paraprotein, at least. Yeah. Because you don't know who's getting the specimen. If it's a derm, you would hope that they know to do that. But, it could be anyone who did the biopsy.
So, looks like there's kind of these fissure deposits in the dermis.
Fissure deposits in the dermis? What can cause that?
Amyloid.
Yeah, exactly. So that's what amyloid looks like. And then, there's primary or secondary systemic amyloid. Okay. So this is a special stain, and it is a Giemsa stain. So Giemsa, H and E is hematoxylin eosin. Giemsa is M and E, methylene blue eosin. This is a trick question. What color is methylene blue? Blue! Well done! Well done! So when it stains, instead of blue, when it stains purple, you call that what kind of staining? Metachromatic. So metachromatic staining means you've got a stain like methylene blue, and it's not staining blue, it's staining purple, right? So that's metachromasia, right? So here you have metachromatic purple staining with methylene blue, which is typical for certain types of acid mucin and mast cell granules. And so this is a mastocytoma. I don't know why it's in this box, because that's not even a bullous mastocytosis mimicking PCT, but...
So, looks like there's thick collagen, and then you see some fat below.
Collagen, some fat.
There's some space between the collagen.
Yeah, there's some space between the collagen. So if the history is right, this could be...
I guess it could be sclerodema.
Yeah, and that's what it was clinically, apparently. But again, sometimes you see tons of mucin and sometimes just some fenestration, and it can be subtle. Let's see what else we have to do here.
Looks like in the papillary dermis, kind of some amorphous kind of material.
Yeah. And where is the material? Is it around anything in particular?
Like a post-cap venule maybe.
Yeah, so it's around vessels.
Right. So I would think if it's superficial, you think of EPP, PCT if it's not quite as much, and then lipoid prognosis if it's superficial and deep.
Yeah, so if it's superficial and deep, that kind of deposition, you think of lipoid prognosis. If it's not that much and superficial, you think of porphyria cutanea tarda. And when there's a fair amount, but it's all superficial, you think of erythropoietic protoporphyria. So in this one, do you see any deep
Yeah,
around the sweat glands? Not really.
Not a ton. Okay.
But you got a fair amount up
amount.
high, so
I go
this is
EPP.
probably EPP, which is what it was. And then how are you going to screen for EPPs? You're going to send them for urine porphyrins?
They're normal.
Urine are
Empty
normal
EPP.
because EPP stands for empty PP, right? So there ain't no P in EPP, right? So it helps you remember that you can look at blood porphyrins, but you're not going to. There is no urine porphyrin abnormality in EPP. So no P in EPP.
Kind of cut a little oblique here. Looks
Yeah,
like
kind of
it's-
a little oblique, and the biggest thing is you got almost an abscess, neutrophilic, down there, so that has to be explained, right?
Mhm. So I think doesn't seem to be totally equine with the newts.
And your dermis is a little cellular,
Yeah.
and then you've got these things. So what are those things?
They almost look like clots.
Almost look like clots, but what's in them? What are they forming around?
Are they fungal organisms? Or
Those are all elastic fibers. So it's osteoid that's forming in lumps around elastic fibers, sometimes with an elastic fiber sticking out of it like the stem of a lollipop. So these osteoid with elastic fibers or lollipop bodies, characteristic for
NSF?
Yes. So NSF or nephrogenic systemic fibrosis, which is where they were first described back when that was its name, or Dr. Brodel and Rob used the term gadolinium-associated plaques to emphasize that not all the patients have systemic disease. They're all valid names. And so, Dr. Cowper, I think, would say that, well, that was the idea when nephrogenic fibrosing dermopathy was first described, was that it was skin changes, and then the potential for systemic was described. But it's important that everyone realize that they don't have to have systemic disease, but it does mean gadolinium exposure. So, important lesson and important thing for patients. And you can see a little bit that you've got a busy dermis there. Not a whole lot of mucin evident in this particular example, but when you have that osteoid around the elastic fibers, you can say it is likely a bona fide example of gadolinium exposure. So.
It's from acro skin, and there's pink amphiphylix, and with around the small vessels.
Yeah, so there is some stuff depositing there around the vessels.
So it could be PCT, could be EPP.
Yeah, it's a little heavy for PCT. The skin is definitely a little papillomatous in this case, almost like an acanthosis nigricans change. And this was again a patient with sort of velvety, thick skin of EPP. Very good. That's the skin surface.
Looks like there's a lot of mucin down deep.
Mucin down deep, pushing the collagen apart.
Scleroedema.
Scleroedema associated with?
Diabetes, strep, gumopathy.
Yeah, those would be the biggies. So that's your piece of skin.
Looks like there's maybe some entry space between collagen bundles.
Tell me about the cellularity of the dermis there.
There's not many cells.
Yeah, not many. That's pretty much normal for a dermis. How about up here? Tell me about the cellularity up there.
Increased a little bit.
Yeah, it's like a busy dermis up top.
Scleral mix, maybe, if it's only up top.
So, and this is a patient with a paraproteinemia. And, you don't pick out, your eye doesn't pick out that much mucin. And that's usually the case, that your eye doesn't pick up that much mucin. But what it does pick up is that there's fine, new, ropey collagen and a lot of fibroblasts. So it's part of your busy dermis differential. And, busy dermis is everything from dermatofibroma, interstitial GA, syphilis is in your busy dermis differential, and scleromix is in your busy dermis differential. So, ropey collagen, too many fibroblasts, and that led to the discovery of the paraproteinemia and plasma cell dyscrasia in this patient. How are we doing time-wise? We're getting there. Okay.
We have some material around some of the postcapillary venules, almost it looks like. Some of the areas. I don't know if that's like fibrin down there with the more darkly or deeply staining.
Yeah, that probably is a little red cell extravasation, hemorrhage, fibrin.
It's not, kind of concentric pink material around the vessels. Makes me think of like EPP or.
Yeah, and that is EPP.
Got a pretty typical mix.
So through and through, what's the difference between, why isn't this scleroedema of Buschke?
It's thickness.
And what else?
The collagen is wispy.
Collagen's wispy, whereas the collagen's normal and scleroedema just pushed apart. Okay. So very good. Let's see what else we got here.
So I got some deep punch biopsy on the fat. There's lots of dense collagen. Not really pushed apart. Maybe could be.
Yeah, maybe a little bit hard to tell. Is a diabetic patient upper back, so it probably is scleroedema. So what's wrong with this slide?
There's spindle cell higher in the dermis.
Yeah, so you've got spindle cells, nuclei, lots of nuclei. Tell me about the collagen. If this is an adult, is that normal size collagen?
No.
No, you got lots of fine collagen bundles and lots of nuclei in a dermis.
So it's like scleromyxedema.
Like scleromyxedema. And scleromyxedema, what's their chance of getting out and out myeloma? High or low?
Low.
Really low. It never goes to myeloma, so it's a good disease to have, right? No, it's a horrible disease.
Yeah, I was like, wait a minute.
It's a horrible, disfiguring, terrible disease you wouldn't wish on anyone. They don't go on to myeloma, but the disease process itself is like a horrible scleroderma-like illness.
Like 3 to 6 months is what some of the things say as far as prognosis.
The patients I've seen, they live a long time, but their quality of life is horrible. I mean, it's really a devastating disease. So, low chance of myeloma, but still not something you want. Okay, what's this likely?
Fissured material.
Big masses of fissured material, probably.
Amyloid.
Amyloid, okay.
Alright, so another pale slide. It looks like the collagen's smushed and kind of longitudinally oriented. There might be some increased fibroblast up real high, but
Do you have fine ropey collagen, or do you have smudged collagen and loss of space between collagen bundles?
it's smudged and loss of space.
And does your biopsy taper normally, or is it kind of squared off?
It's square. The only thing that's throwing me off is the fat around the eccrine glands, but it could still be dysmorphia.
So it's not deep. So you have preservation of your periadnexal fat, which is a little odd.
Right.
Could be a superficial morphia, or
Right.
could be a morphia look-alike. So other conditions that look just like morphia histologically, sclerodermoid graft versus host, can look very much like morphia. In this case, this is sclerodermoid porphyria cutanea tarda. So this is someone with long-standing PCT with a scleroderma-like presentation, but there's some odd things about it, like preservation of the periadnexal fat. So, could it just be superficial morphia? Sure it could, except this patient has long-standing PCT, so it's sclerodermoid PCT. So vinyl chloride exposure can give you a scleroderma-like illness. People in the record-making industry got that. You can get it. Sclerodermoid GVH and sclerodermoid PCT are probably the closest lookalikes histologically to true morphia.
It's like DM, or just like sclerodermoid, DM, or connective tissue disease. They have more features of like a connective tissue disease.
They tend to have more other features of connective tissue disease, but mixed connective tissue disease where you have DM overlap with scleroderma, basically, the biopsy can look very much like morphia scleroderma as well. Okay, let's see where we are. We got just a little bit. You want to grab a potpourri box, and we can start flipping those back in. Grab some of those, and then these go in other boxes. Let's grab at least a couple of these, because you should be starting to think outside the chapter. Okay, Shane, what's that? Yeah, this tumor.
Fibroepithelioma pincus.
Yes, very good. So fibroepithelioma pincus, very good.
That's a Shane favorite.
I called him Shane last year.
Kind of cup-shaped. Maybe with a good buttress, could be KA if it's more end.
Yeah, so buttress, crateriform, glassy, probably keratoacanthoma. No, that's a little too pale. Let's do a different.
Okay. So in the junctional, there is well lasted in the junctional. A little bit of confluence.
And does it end in a nest?
It's on the nest.
So it's well circumscribed, it ends in a nest, it's well nested, as you said at the beginning. So it's probably malignant or probably benign?
Probably it's a Spitz livers.
So it's probably a type of Spitz nevus. This one has small spindled cells and is a dark lesion that erupted on the thigh of a young woman. So this is pigmented spindle cell nevus of Reed, which is a type of Spitz nevus. Very good.
Seem to be a lot of circumscribed islands of cells in there.
Yeah,
Surrounded by
circumscribed
red
islands,
border.
nests, theques, whatever you want to call them. And the nuclei are all the same or pleomorphic?
Yeah, pleomorphic.
So pleomorphic nuclei and high mitotic rate, so probably, yeah, a met of some sort, and this one was a melanoma. One of the clues to melanoma, see these cells with the pink cytoplasm and the eccentric nucleus? Looks like a rhabdomyoblast from rhabdomyosarcoma, so it's called a rhabdoid morphology. So rhabdoid is eccentric nucleus, ample pink cytoplasm. That's a very typical morphology of melanoma, rhabdoid nucleus. Okay, and with that, we will stop.